So let's discuss about clinical approach to preliminary eye examination before contact lens fitting. So today's topic is preliminary eye examinations. Okay, let's move further. So what are the contents? What are the things that we are going to discuss? Basically, routine preliminary examination before contact lens wearing. Options for wearing modality and lens replacement. Definitely, it's depend upon the preliminary examination and what we find on the examinations. So on the basis of that and on the basis of history, definitely we are selecting wearing modality, or we are definitely suggesting wearing modality, and we're thinking about replacement modality. Lens dispensing and patient education, definitely it is a lot depend upon preliminary examination. Yes, preliminary examination history itself is in preliminary examination, and I think we have made one video which is separate video for the history, which is detailed video. I think that will be better, but we will definitely going to talk about history today also. So conducting lens aftercare visit, definitely preliminary examination, then dispensing, then after patient wearing, we think about aftercare. Yes, aftercare visit. But definitely preliminary examination is directly correlated with the aftercare visit. We make our mind for aftercare visit as an optometrist by preliminary examination itself. Yes, slit lamp examination and contact lens of the patient. So contact lens patient. So we definitely talk about it a little bit. So what are the routine preliminary examinations? Definitely first is always a history, not just a history, a thorough history. Very important. Okay, slit lamp examination of anterior eye segment. We want to know whether there is some absolute contraindications, for example, infections or anything. Or we want to know if there are tear film and all these things. Yes, definitely. Then, what is another important point is ocular dimensions, especially sag height, or maybe pupil diameter, most important corneal diameter, corneal radius of curvature, even for the now latest technology with not just keratometry, but from what you call topography, we have different shape factors of cornea, and we want to know how that cornea is shape is, diameter is, pupil diameter, and all the condition is scotopic, photopic, and uh, mesopic, so all the things. And assessment of the tear film, which is very important. Yes, we always want to know what's the status of tear film before contact lens fitting. Yes, definitely. Spectacle refraction, that's a very, very basic thing. Without spectacle refraction, how can we prescribe contact lens? How can we determine contact lens power? It's centrally important. Yes, yeah. So let's move further. So history, as I have already discussed in my previous video, good history includes patient's reasons of wanting contact lens. We want to know, and we must know what are the reasons. For example, some patients want for the cosmetic reason, some patients want to get rid of the spectacle, some patients want to enhance their iris color, or change, they want to change their eye color for cosmetic purposes. Some patients want for the visual purposes, optical purposes. Yes, it's very important why they want, why patients want the contact lens, and we must know, is their wanting or their reason for contact lens wearing is based on the reality or not. Sometimes they have fantasy. Yes, that's really bad. And another is ocular history. We want to know whether I has any surgeries or any disease other than, yes, refractive error is not a disease, but yes, other conditions that is continuous in any therapy, ocular therapy, or anything. We have to know or ocular history. We have to know medical history, which is very important. Any previous contact lens history, and especially any previous contact lens bad history. What do you mean by bad history? That bad encounter with contact lens. If patient has such a history, we have to know if there is any bad encounter with the contact lens, when patient has any bad memory with the contact lens. It's very important. It's a good history guide clinician in determining which test to perform and expect result from those tests. Yes, definitely. With the history, we as an optometrist guided towards the test. Yes, many times, many times, like 99.99999%, history determines which are the test we are uh, definitely ordering or anything else. So that's why, yes, it's also depend upon our objective judgment, but many times history is that important. Also, history also add the practitioner to recommending appropriate contact lens type, isn't it? Definitely. Care regimes, definitely. Wearing schedules, definitely. If patients some are frequent flyer, then we it's better than we prescribe silicon hydrogel contact lens daily disposable, isn't it? Because if he's frequently flying, then frequent weather changes, and sometimes they can manage contact lens solution, or sometimes contact lens can be out of the eye all of a sudden and they can lose their contact lens. But at the same time, if we prescribe daily disposable, they have extra pairs of contact lens. So we have to go according to patient's history. It's very important. Okay, fine. So reason for contact lens one many times is cosmetics. So many times it's inconvenience of glass uncountable and gets misplaced or broken, or its glasses being very dusty frequently, and they want to get rid of it, so they want contact lens. And sometimes it's about the vision, especially in case of high metropia, high astigmatism like keratoconus or corneal distortion case. Patient depend upon the contact lens, especially clear contact lens or rigid RGB contact lens, and they are very good contact lens for enhancing their quality of life. Yes, and sometimes patients want because of sports or their recreational purposes. Yes, sometimes they need occupational, for example, celebrities or movie star when they are making movie actually, so they want prosthetic contact lens. Or many much flight attendants, they want contact lens for cosmetic purpose, they want to get rid of their glasses. Yes, and few times, not that many times, but few times, uh, therapeutic contact lens, which is sometimes it's like real important contact lens, for example Steven Johnson syndrome. Yes, therapeutic contact lens gives the patient another life, which is very helpful contact lens. Yes. So ocular history, what are we talking about? Ocular history, previous glasses, contact lens wear. Yes, definitely previous strabismus, amblyopia, or is there any surgery done, or history of eye trauma, or history of ocular allergies is very important. And recurrent ocular infection or inflammation, is there any recurrent? Yes, for example, it's not infection or inflammation, but for example, recurrent epithelial erosion. Yes, then we must think about um, therapeutic contact lens, not other contact lens, for example, not corneal contact lens. Yes, topical ocular medication, is there continuous use in, for example, glaucoma? Yes, they're using anti-glaucoma medications, which is very important. Medical history, is they have seasonal or chronic allergy, is there continuous sinusitis, dry mouth, eye, or mucous membrane, is patient is diabetic or not, or they have collagen vascular disorder disease like rheumatoid arthritis, SLE, or they're pregnant or not, or they have thyroid dysfunction or not. Systemic medication, like example antihistamines, anticholinergics, and some beta blockers, yeah, and even antidepressants and oral contraceptives, because all these medications directly affect the uh, tear level, and affected tear level will definitely affect the contact lens fit, even contact lens well-being. Yes, and one of the pathological thing is unrealistic expectation. That's very pathological. It's our duty as an optometrist to make sure that our patients has realistic expectation. If they has unrealistic expectation, it will be catastrophic. Yeah, so you must understand the patient is having realistic expectation or not. Is his or her not having that realistic expectation, just stop there, and you have to counsel your patient first, and then you proceed. Otherwise it will create havoc for you too and for your patients. So it's very important that you must win your patient first psychologically. You must counsel well, you must do your right thing to do. Unrealistic expectation is very bad thing. If your patient has unrealistic expectation, you must be cautious, and you must counsel him or her. Okay. So contact lens history is another important thing. If the patient is currently wearing contact lens or has worn contact lens in past, definitely I have already told you. If patient has some really bad experience with contact lens, it's very important. It is important to determine why person desire to refit if he already had contact lens, and what are the causes that he left that contact lens using contact lens, that left that habit of using contact lens. Yes, useful to select appropriate lens material and design, definitely. So if he has history of contact lens wearing and why he left wearing contact lens and why he want to fit again, it's very important that you must ask these questions. Type of contact lens and the patient wearing. So what kind of contact lens patient is wearing? Is he satisfied or not? Is there any symptoms or not? Especially symptoms like discomfort. Discomfort is one of the major symptoms why many contact lens wearer, especially new contact lens wearer, ceases to wear contact lens. It's very important, especially discomfort. Reason for discontinuing or desiring a change. Why they are why they have discontinued or why they have desired to change. It's very important when you ask patients about contact lens history. Definitely you want to know what is his or her current replacement schedule, or is there any history of complications. I have already told you, from I think I told you like 3 or 4 times what could be wrong. Yes, definitely. And what was wrong, if there was wrong in his history, if there was anything he has that bad experience with contact lens, it's central important. That's why history of complications, if he or she had anything in his uh, past. Yes, yes. Let's move to the slit lamp examinations. So what are the things that we definitely want to examine in slit lamp examinations in anterior segment, especially preliminary examination of contact lens? The routine slit lamp examination for anterior segment is necessary to ascertain existence of any contraindication of contact lens. I have told you absolute contraindication of contact lens is infection. Just look at the signs of infection. Is there anything? And definitely, we want to know other aspects, like, for example, blepharitis, for example, heavy mammalian gland dysfunction, isn't it? Yes. Prospective contact lens wearer who proves to be borderline contraindicated need special assessment. Special assessment means what? If someone uh, is having blepharitis, if someone is having mammalian gland dysfunction, then we have to be cautious. Yes, use a higher magnification and illumination technique will better disclose entire segment anomalies. It's central important. Use whatever magnification or illumination. Yes, suggested higher magnification and illumination, but you have to disclose if there is any entire segment anomaly, especially at the ocular surface anomalies. Yes, because contact lens is going to land on the cornea or is scleral in conjunctiva, so it's central important. It will going to interact with the upper lid conjunctiva, so that's why you have to examine everything. Yes, especially blepharitis, mammalian gland dysfunction, tear function, and all these things. So slit lamp can also be used to assess the tear. Obviously we are always assessing tear breakup time, especially invasive tear breakup time. Yes, and perform before any trial lens fitting to identify possible contraindications, also to establish baseline for the appearance and conditions of anterior segment before the contact lens is applied. So we do not apply directly contact lenses. We first examine anterior segment through slit lamp, and we want to know if there is any contraindications. Yes, it's very important. Repeat during and after the trial fitting assessment and fit and detect if there are any segment. Yes, it's not about just saying first time, very first time, like preliminary examination. We will definitely use slit lamp during the fitting. Definitely, slit lamp is a very important instrument for us while fitting contact lens, no matter what, scleral lens or no matter what, soft contact lens, RGB contact lens, no matter corneal contact lens or whatever. But slit lamp is always very important instrument during the contact lens fit. Yes. So measurement of ocular dimensions. What about ocular dimensions? The most important of all is corneal curvature. Yes, radius of curvature. Yes, what do we call? We want to select best curve of the contact lens. Definitely corneal diameter, pupil size is measurement, especially scotopic and photopic conditions. Yes. So assessment of the lead and characteristics. Definitely we want to know whether our lead is tight or loose, whether lid position is, or especially lower lid position and upper lid position. Definitely, lower lid position is exactly at lower limbus or not. And elephant of the room is assessment of tear layer. Yes, it's very important. So, what about the corneal curvature? So, basically, corneal curvature, cornea, central and peripheral keratometry is very important. But yes, keratometry isn't limited to the center. But with the help of topography, we can simultaneously view center and periphery. Corneal topography is very, very good instrument, and because of corneal topography, our life becomes very easy. Uh, our life as a geometrist, yes. Shape and irregularity. That's all about corneal topography. So I don't think keratometry will give us the pure idea about the shape and regularity of contact lens. It's like almost impossible. Degree of corneal or internal astigmatism. What do you mean by internal astigmatism? Internal astigmatism means astigmatism except the front surface of cornea. Astigmatism due to except the front surface of the cornea, or astigmatism because of posterior surface of the cornea, or lens, or tilting of the lens, or tilting of position of the macula, or whatever. Okay, definitely corneal curvature is definitely going to correlate with the spherical to cylindrical ratio. Yes. So central corneal curvature can be measured with keratometry, which is ophthalmometry, but not periphery. The accuracy of plus minus 0.02 mm is desired for the mean 3 keratometry reading for each principal corneal meridian. Peripheral cornea, definitely. Nowadays, corneal topography, no matter what, it's bone cirrus or the pentacam or the Galilee, we don't care. All good. The regularity and the magnitude of corneal and internal astigmatism influence the design and suitability of contact lens. Definitely, if there is high internal astigmatism, we do not prefer spherical RGBs. Yes, we prefer front uh, bitoric, basically, or soft toric contact lens. So it's very important to differentiate whether astigmatism is corneal, especially anterior surface corneal, or internal. Yes, it will also keratometry will also help us to distinguish these two factors. In some cases, spherical lens provides satisfactory visual acuity when the spherical equivalent of ocular refraction is incorporated. Definitely, especially in soft contact lens, if there is this rule, 4 is to 1 rule. Yes, if especially spherical soft contact lens may be satisfactory in case of where astigmatism to eye is very less, or cylinder is 0. Approximately 25% to sphere. For example, if sphere is -4 and cylinder is 0.75, at that case we can definitely do spherical equivalent, which is divided by 2, eventually 37 something, and we have to definitely do vertex distance correction. That's all it. So this is 4 is to 1 rule. Yes. So cornea and pupil. So cornea, whenever measuring diameter, so it's horizontal visible iris diameter. So we don't use vertical visible iris diameter, but we use horizontal visible iris diameter. Pupil, especially pupil, yes, ideally through book, it's called scotopic, mesopic, and photopic. But in clinical setup, we prefer scotopic and photopic. We don't think much about mesopic. Yes, we think about scotopic and photopic. So corneal diameter measure should include horizontal and vertical dimensions, but we prefer horizontal visible iris diameter. Measurement are made from the limbus to limbus across the central pupil using suitable millimeter rule, or nowadays very easy with the corneal topography. They totally give automatically. So horizontal and vertical dimensions of the cornea are based on horizontal visible iris diameter and vertical visible iris diameter. Yes, approximately 10 to 13. Pupillary measurement. Measurement of pupil are made using millimeter rules, or nowadays pupillometry too. Yes. So basically, pupil is small if it's less than 5 mm, medium 5 to 7 mm, large greater than 7 mm in scotopic definitely. So why it is important? Why measuring pupil diameter is important? Because the result acquired under lower illumination, just remember lower illumination, not in higher illumination, are useful if possibility of visual disturbance resulting from BOZD. So what we want that the largest diameter of the pupil, which is possible definitely under lowest illumination, which is scotopic. We want our BOZD of the contact lens. It's covered, fully covered. Okay, fully covered during that lower illumination. Yeah, condition that is smaller than the pupil is to be eliminated. Basically means we don't want our pupil size is larger than that BOZD, and we don't want our BOZD that it cannot cover that pupil size. So we want in scotopic condition to BOZD completely cover our pupil. Yes, that's finished. So measurement under the lower illumination are difficult, especially in eye with a dark iris. Use UV lamp is possibly associated with a clear rule or fluorescent marking, or maybe measuring pupil under the lower illumination. Alternatively, light source, for example, ophthalmoscope, can be used to sweep beams and the light across the pupil while holding the pupil in the glass. Other suitable measurement skills are closing the eyes. Yes, nowadays it's very easy, but yes, definitely ophthalmoscope is another good way to measure the scotopic pupil size. So, assessment of the lead characteristics. What are the lead characteristics? The significant difference between the lead characteristics and different races, because lead characteristics are different in Caucasian versus Asians, especially in terms of papillary fissure. Yes, Asians papillary fissure is smaller. Asians lead tension are much higher. Yes. So, and why it is important? If papillary fissure is smaller, yes, then we must think of a small total diameter lens. If papillary fissure is larger, we must think larger total diameter of the contact lens. They are directly proportional. Yeah. So interpapillary aperture size and the shape of the Asians are smaller, with a more acute interpapillary angle at the inner and outer canthi. So measurement of papillary aperture is to be made with a millimeter rule from the upper lid margin to the lower lid margin across the center of the pupil, while eye is at the relaxed primary gaze position. Gaze position is very important, and I think you guys must read all these things, how to measure papillary right, and doing all the MRD1 in your oculoplasty postings. I think you guys have learned it, but if you are not good with this uh, measurement, you must learn. Okay, so RGP wearer, the papillary aperture is approximately 0.5 mm smaller than those of non-wearer because of the complications of RGP in long term. So RGP, one of the complications of RGP is reducing the papillary aperture size. So soft contact lens, it's just a study. Okay, so lead tension, no accurate method of measuring the lead tension is exist. Lead tension measurement is just our subjective feeling. Yes, as an optometrist, asking patient to look down and pulling the upper lid outward by grasping the eyelashes gently. Subjective grading is to the resistance of pulling from +3 is very tight and from -3 is loose. So I want to emphasize you that lid tension is not some objective measurement. It's a subjective measurement done by a optometrist. Okay, that's very important. So for both rigid and soft lens, lid tension significantly influence the lens centration and movement. That's a very important point. Is this higher lid tension causes greater lens displacement on blinking? That's the good point. You have to understand this. Why lid tension is important? Higher the lid tension causes greater the lens displacement while blinking. Okay, so difference of opinion exists concerning the benefit of fitting larger or smaller diameter soft lenses on the patients with a tight lid. The larger diameter RGB lens with thick minus carrier may ride high under the lid tight. So sometimes it asks in the MCQs too. A larger diameter RGB lens with thick minus carrier may cause lens to ride up, yes, while a smaller diameter may cause lens to push down. So basically, ride low. So high plus lens may be thick center displaced downward. Yes. So another important point, what is blink rate and why we have to measure blink rate in preliminary examination of contact lens. Normal involuntary blinking is a result of tear evaporation and tear film breakup being sensed by the cornea. That's why normally we blink. An adequate blink rate is necessary to prevent desiccation of ocular surface. That's what we have to know. See, if the tear breakup time is smaller and we don't blink, then what happens? Our ocular surface desiccate, and what happens? Epithelium get eroded. That's why we see that staining in epithelium. Yes, corneal epithelium. So partial blinking may result in superficial punctate staining of cornea. Yes, definitely. That's what I'm talking about. Normal blinking rate should be measured without patient's knowledge. Don't say to your patient, just I'm measuring your blinking rate. Because if you told them, they will be conscious for their blinking rate. It's like disguising something. You don't tell your patient that I'm measuring your blinking rate. Just simply measure it. And amplitude, you must not only talk about blinking rate like 6 blink per minute or 10 blinks per minute. You have to measure or just think about the length of blinking, completeness of blinking. Sometimes people blink partially, especially RGB wearing patients, and awareness may be invalid the results. That's important. You have to understand 12 to 13 blinking per minute is roughly normal. Yes. So I think I will start my next video on this particular topic, part 2, from this slide. So I think I must stop here. It's already 26 minutes. Yes. So bis dann, tschüss.